My name is Sarah Crager, and I'm a current critical care fellow at Stanford Hospital. Today I'm going to talk to you guys about a unified approach to ultrasound assessment of fluid status. And this lecture is really going to focus on putting together a number of different ultrasounds that you guys already know how to do from previous lectures in this course, and focus on the big picture approach. Because for fluid management, knowing how to technically do the ultrasounds is just not enough. You need to know what they mean, what they don't mean, and how to use ultrasound to help you put the full picture together. Fluid management in critically ill patients is a hugely controversial topic, and I don't have any definitive answers for you today, but as that this is an issue we're all forced to make decisions about every day, for me, I think a reasonable starting place for both my practice and this talk is the following, keeping it real simple. We know that inadequate fluid resuscitation is bad. It's also becoming increasingly clear that excessive fluid resuscitation is also bad. So if too much is too bad and too little is too bad, the question becomes, how do we get it just right? And that's what we're going to talk about today in this lecture. But first, a disclaimer. Fluid administration is a complicated clinical decision, and none of us should be making any complicated clinical decisions just based on one test or number. And that's why I'm not going to try and convince you of the magical merits of any one ultrasound tests that will allow you to just turn your brain off when you're managing your patient's fluid status. Because again, no single test is going to give you the answer. That being said, what we are going to try and do today is give you a big picture strategy for how you can use ultrasound in a systematic and focused way in combination with all of your other clinical data points to help you approach this complicated question. First, it's absolutely necessary to understand some key physiology here, because it directly relates to how you're going to use ultrasound to help you answer these questions. So we're going to now spend a little bit talking about the physiology of fluid responsiveness and fluid tolerance. Let's start with fluid responsiveness. Fluid responsiveness is an increase in the patient's stroke volume in response to fluid administration, because fundamentally the only reason to give a patient a fluid challenge is to increase their stroke volume. If the fluid challenge does not do that, it serves the patient no useful benefit and may in fact be harming them. We all remember the Starling curve, right? From med school, the ability of the heart to change its force of contraction and therefore stroke volume in response to changes in preload. It's called the Frank-Starling mechanism. And really what we want to know in the question of fluid responsiveness is my patient operating on the steep portion or the flat portion of the Frank-Starling curve? That's the fundamental question we're trying to figure out. So first, let's talk about what does not answer that question, and CVP. It turns out that CVP simply does not answer that question. CVP is useful for a lot of things, but fluid responsiveness simply isn't one of them. I think it's important to understand why. Let's talk about what CVP is really measuring here. So CVP gives you a single value for ventricular preload. The problem with that is that a given value of preload can be associated with fluid responsiveness in the case of patient 1, or fluid non-responsiveness, as in the case of patient 2, because fundamentally an assessment of preload is not the same as an assessment of preload responsiveness. So how do you measure fluid responsiveness? Well, if you really want to do that, what you need to do is challenge the Starling relationship. What you do to challenge the Starling relationship to get at this issue is you take your patient from preload point A to preload point B, and then you see how they respond. And only by looking at what happens on the y-axis of this curve with stroke volume, in response to that fluid bolus or fluid challenge, can you differentiate your preload responders from your non-responders. All right, this is the concept of fluid responsiveness. Now let's take a moment and talk about fluid tolerance. Fluid tolerance, I think, is something people are less familiar with. The concept here is that fluid administration does not precipitate deleterious cardiopulmonary effects. So why? Why is too much fluid bad for patients? There's probably a lot of reasons, but this is certainly a big one. This is something none of us want to see on our patient's chest x-ray after we volume resuscitated them. And it turns out that pulmonary edema like this is probably bad in and of itself, obviously, but also a marker for other badness, because increasing numbers of studies are telling us that extravascular lung water, a quantitative measure of pulmonary edema, is an independent predictor of mortality in critically ill patients. And so It should now be clear to you that when you're fluid resuscitating your patient, you should really understand the relationship between extravascular lung water and preload. So let's talk about it. We already talked about the Starling curve, which is the relationship between preload and stroke volume, but the relationship between preload and extravascular lung water is equally important, and it looks something like this. What I want to point out to you about this curve is that it has an inflection point. And once you get past that inflection point, then a small change in preload can result in quite a big change in their extravascular lung water. Something else I want to talk about with this curve is what are factors that shift that curve to the left. And what I mean by shift that curve to the left is that for a given value of preload, your patient will have an increased amount of extravascular lung water. And as you can see in the case of the blue curve, in the case of that patient, that point of preload is before the inflection point. In the case of the red patient, that preload point is now after the inflection point. So this is significant. So now, let's talk about what things do that. What are factors that shift this curve to the left? There's many of them, but here are the four big ones. Increased capillary permeability, glycocalyx injury, decreased oncotic pressure, or increased hydrostatic pressure. And what I really want to highlight here is that three of these four things have nothing to do with your cardiac function, have nothing to do with your LV systolic or diastolic function. Okay. So we've talked about fluid responsiveness. We've talked about fluid tolerance. Now, let's go back to the bedside where we are managing our fluid status for our patient, and we're trying to still figure out how do we get it just right. And the way that we get it just right is we got to think about these two curves together at the same time. So in the fluid responsiveness curve, you want your patient to be just past the steep portion of the curve. That's the optimal place for them to be. In the fluid tolerance curve, on the other hand, you want your patient to be just before the steep part of the curve, which is where you want to be. And how the implications of all this play out, I think, really come together when you graph these two curves on the same graph. And the thing I want to highlight here is that fluid responsiveness does not necessarily equate to fluid tolerance. And it's really important that you don't conflate these two things. Let me show you why. So let's say this is our patient. We have their Starling curve in the red and their extravascular lung water curve in the blue and preload on our x-axis. All right, let's say we're at preload point A. We give our patient a volume challenge and take them to preload point B. For that preload point B, for that volume challenge, they have a pretty large increase in stroke volume, which is a good thing, for a relatively small increase in extravascular lung water. Is this a patient you want to give fluids to? Yeah, absolutely. All right, what about this? Now we're at preload point C, and we take our patient to preload point D. That gives us a pretty small increase in stroke volume, but for a pretty large increase in extravascular lung water. So technically, is this patient fluid responsive? Yeah, they are, right? They had an increase in stroke volume in response to a volume challenge. But are they fluid tolerant? No, because you've just taken them past that inflection point at the curve. And is that large increase in extravascular lung water worth that small increase in stroke volume? You know, it's hard to say. Depending on the clinical context of the patient and all kinds of other complicated factors, that's your decision to make. And what that means for how you run your resuscitation is up to you. But it's important that you understand the costs and benefits of what you're doing with that fluid bolus and what it means for your patient. So the bottom line is that this is the picture I want you to have in your head when you're at the bedside trying to think about giving your patient more fluid, that your goal in fluid management is to hit this sweet spot. All right, that's all well and good, but how exactly do you go about doing that at the bedside? And that's what we're going to talk about now. We're going to talk about a bedside ultrasound approach to volume status assessment, where we assess this physiology and then figure out what to do about it. I like to keep things simple, so we're going to do this in a 3-step approach. Step 1, how narrow is my patient's therapeutic window for fluid administration? Step 2, will I harm my patient by giving them fluid? And step 3, will I help my patient by giving them fluid? So let's go through each of these by turn and talk about how you can use ultrasound to help you answer each one of these questions. Let's start with step 1. How narrow is my patient's therapeutic window for fluid administration? And here, what you're really trying to do is get a sense of the slope of your patient's Frank-Starling curve. So this is where you do a bedside echo looking at left ventricular function. And I'm going to refer you to Unit 2 of this lecture series, the lecture on left ventricular function by Drew Patterson, in which he goes through the details of how at the bedside you get a gross sense of left ventricular contractility. And in this particular case, when you're using it in this context, you're not trying to figure out if the patient's LVEF is 37% or 39%. You're just trying to get a gross sense of their contractility to figure out whether the shape of their Starling curve looks more like this. They have great contractility, maybe even hyperdynamic. Looks more like this, maybe moderately okay, or looks like this, where it's significantly depressed. Because really what you're getting at here is, what is my margin for error? Do they have a wide therapeutic window for fluid administration or a narrow therapeutic window for fluid administration? Like this. Because this patient with a super narrow window, just because they have terrible LV function doesn't necessarily mean they don't need a fluid bolus. You just have to know that this patient may have a very narrow margin for error here and a very small window that giving fluid is okay. And so rather than giving a big bolus up front, I might do something like thoughtfully give smaller serial boluses with very frequent reassessments. All right, now let's talk about step 2. Will I harm my patient by giving them fluid? And this is where we're going to assess fluid tolerance with lung ultrasound. So when we're using lung ultrasound for this purpose, we're looking for the difference between dry lungs and wet lungs, basically the difference between A lines and B lines. For a detailed description of how to perform this ultrasound, please take a look at Unit 5, the Interstitial Syndromes lecture by Sarah Nickervan. The question for this lecture is how we are going to use lung ultrasound in our systematic ultrasound assessment of fluid status. Because it turns out that lung ultrasound is a really, really good way to assess extravascular lung water. This was a great study that came out in Critical Care in 2015, and it compared ultrasound chest X-ray and CVP to a gold standard thermal dilution method of assessing extravascular lung water, the extravascular lung water index. And as you can see, ultrasound did pretty good. The other thing, though, that I want to highlight from this study is that this study found a clear relationship between the number of B lines on lung ultrasound and the degree of extravascular lung water. If you fit a curve to this graph, it looks something like this. What does that shape of that curve remind us of? It reminds us of this curve, right? The relationship between preload and extravascular lung water. And just like this curve having an inflection point, this curve also has an inflection point. And so clinically, you want your patient to be right about here, safely before the steep portion of the curve. And what that means clinically when you're using this at the bedside on ultrasound is that you want your patient right about there. And what that corresponded to in this study is approximately 3 or more B lines per field. And so when I'm assessing my patients, if I'm seeing more than 3 B lines per field, I'm getting concerned that I'm heading towards that steep part of the curve where I want to be. If I'm seeing 3 or less B lines per field, I'm feeling pretty okay that I'm still on the flat portion of the curve and that my patient is probably fluid tolerant. All right, let's move on to step 3. Will I help my patient by giving them fluids? And here's where we assess fluid responsiveness, and this is where things get a little bit more complicated. So, remember how our whole goal here is to figure out if my patient's operating on the steep portion or the flat portion of their Frank-Starling curve. And we talked about how we do that is to challenge the Starling relationship. Okay, that's great, but how are we going to functionally translate this to the bedside? Here's how we're going to do this. So remember, this is a 2-step process, right? We need to do a preload challenge, induce a change in preload, and then measure the hemodynamic response. And how we do this at the bedside, or at least how I do this at the bedside, is as follows. I induce a change in preload with a passive leg raise, and then I measure the hemodynamic response using ultrasound to obtain a stroke volume surrogate measure. We're going to talk about each of these things in turn. We're going to start with passive leg raise. Passive leg raise simply is exactly what it sounds like. You start with your patient sitting up at a 45-degree angle. You lay them flat, you raise their legs to 45 degrees, and that gives them a intrathoracic autotransfusion, which is equivalent to about 300 cc's depending on your patient. And so it's basically like a fluid bolus. Why do I like passive leg raise as opposed to other ways of giving my patient a volume challenge? Well, I like passive leg raise because it's reversible, right? If I'm giving serial fluid boluses to a critically ill patient, I can get myself in trouble, particularly if I think that they're getting close to that inflection point in my fluence tolerance curve, where even a small bolus can really matter. And passive leg raise, you can just sit them back up again. It's nice and reversible. Respiratory variation is something else that people use as a sort of physiologic fluid challenge. And we'll talk about that a little bit more in the context of IVC ultrasound. But the issue with respiratory variation is that it works by far the best in patients who are mechanically ventilated. And not only patients who are mechanically ventilated, patients are mechanically ventilated with no spontaneous breathing activity, at tidal volumes of 8 cc's per kilo, with a PEEP of around 5, who don't have ARDS, which describes just about none of the patients that we take care of in the ICU. And so in a very select group of patients, respiratory variation can work, but in a lot of our patients, they just don't meet the right conditions. It also turns out that passive leg raise is actually quite good. So these are two very recent review articles on using passive leg raise to predict a subsequent response to a fluid challenge. And both of these studies concluded that the ability of passive leg raise to predict a response to a subsequent volume challenge had a pooled area under the curve of 0.95%, which is about as good as you get. So here's how you do this at the bedside. You have your patient sitting up, 45-degree angle. You do your forced stroke volume surrogate measurement. You lay them down, raise their legs, then you do your second stroke volume surrogate measurement, and then you compare the change in your stroke volume surrogate measurement before and after passive leg raise. So what are we using, though, for our stroke volume surrogates? And we're going to talk about 3 different ultrasounds that you can attempt to use for this purpose: IVC respiratory variation, LVOT VTI, and arterial flow velocity variation. We're going to start with IVC respiratory variation. For details on exactly how to do this ultrasound, I want you to go to Unit 3, the Volume Assessment Lecture by Jose Diaz-Gomez. What I want you to talk to you guys about here is what IVC ultrasound means at the bedside in the context of our systematic approach to fluid status assessment. Because it's a little bit complicated, it's not that straightforward, and here is the issue. IVC respiratory variation is not a true stroke volume surrogate. It's at best a correlate. And let's talk about how this plays out when you're using IVC to assess volume responsiveness. This was a great review, came out just a couple years ago, and it looked at all the studies that had looked at IVC respiratory variation for fluid responsiveness. And it concluded 2 things. In mechanically ventilated patients, IVC is a pretty good predictor of fluid responsiveness. In spontaneously breathing patients, it was a lot more equivocal. If there was a ton of variation or minimal variation, maybe, but it was pretty equivocal. And so in this situation, IVC correlates well with stroke volume variation, but not so much in this situation. So to dig a bit deeper on the use of IVC respiratory variation in spontaneously breathing patients, I'm going to refer you to this study. It was a really interesting study that just came out in 2016. It was a review and meta-analysis of about 500 patients from several different studies, and it found that in spontaneously breathing patients, a positive IVC ultrasound, as in greater than 40 to 50% respiratory variation, may be used to predict fluid responsiveness. But a negative IVC ultrasound cannot be used to rule out fluid responsiveness. Now, there's more work being done on this, and there's a couple of recent studies that have just come out that were not included in this meta-analysis looking at trying to standardize spontaneously breathing patients and using a standardized breath to look at IVC respiratory variation. But the jury's still out on that. Keep track of those studies, and it's not enough literature to exactly figure out what it means, I think, and so we'll have to sort of follow the literature and see where it goes. The other thing I want to point out about IVC, though, is that there are numerous confounding factors that can make IVC not mean what you think it means. Anything from ventilator settings to patients' own spontaneous breathing, cardiac conditions, increased abdominal pressure. And the other thing to note about this is that it's not reliable. Some of these are going to give you false negatives, some can give you false positives, some can give you either. And so it can be very tricky to interpret what IVC means in these patients. All right, let's move on to the next thing, the next ultrasound assessment. And this is left ventricular outflow tract velocity time integral, LVOT-VTI. LVOT-VTI is, in fact, a true stroke volume surrogate, which is great. And let's talk about now how to do this. So LVOT-VTI is basically looking at the column of blood that the left ventricle ejects from the left ventricular outflow tract with every cardiac cycle. If you can approximate the volume of that column of blood by measuring the diameter and the length, then we can approximate the stroke volume. And it'll also allow you to calculate the cardiac output. For details on how to get this image and calculating a stroke volume and a cardiac output from a left ventricular outflow tract VTI, I'm going to refer you to Unit 3, the Cardiac Output Lecture by Dr. Adigopala. For the purposes of this lecture, what I want to highlight, though, is that we have a lot of studies that using LVOT-VTI or a delta LVOT-VTI of approximately 10% in response to a volume challenge is a very good predictor of fluid responsiveness, and it's a true surrogate of stroke volume variation. We have a lot of good evidence for this. This is a recent review meta-analysis of using LVOT-VTI in mechanically ventilated patients. And the bottom line is that it had really good sensitivity and specificity. In addition, in spontaneously breathing patients, 4 studies have looked at this. Not huge sample sizes, but they all had pretty good sensitivities and specificities. That being said, LVOT-VTI has a number of limitations. Several of them have to do with cardiac function. If there's an arrhythmia going on, if the patient has valvulopathy, it's hard to interpret these results. But more importantly, I think for most of us, it's really, really difficult to do this study correctly. And if you do not do it correctly, you can come up with really incorrect results. This was a study that looked at teaching people to do this. It taught a number of emergency physicians how to do this, and this was the study's conclusion. After a mere 20 hours of focused training, no differences were seen between emergency physicians and cardiac sonographers in their ability to obtain an LVOT-VTI. So that's great if you train enough on it, but I strongly suspect that most of us, and most of you watching this, are not going to necessarily spend 20 hours of focused training just on this one ultrasound. And again, if you get it wrong, and it's really easy to get it wrong, it can give you very misleading results. And that's why I want to talk to you about one more ultrasound technique that's not ready for prime time yet, but is definitely interesting. And this is another stroke volume surrogate, and what we're doing is arterial flow velocity variation. The idea here is that you pick a peripheral artery, carotid, femoral, brachial, are the ones that we're doing this with mainly. And then you look at the flow velocity variation, or the Vmax, before and after a volume challenge. So this is a fairly new technique. The good news is that it's a lot easier to do. If you can get an image of the carotid artery in longitudinal view, you can do this study. It's a lot easier to do in patients with a large body habitus. It's still subject to a lot of the same confounders as LVOT-VTI, as in arrhythmias, but it's a lot less subject to inter-rater reliability confounders. And studies that we've done have shown that there's much better inter-rater reliability between arterial flow velocity variation than LVOT-VTI, just because it's a much easier study to do. So what's the evidence here? These are the studies that have looked at this. Not too many studies, but several, enough. The ends aren't huge. But one of the biggest problems, and the reason that this isn't quite ready for prime time yet, is as you can see, people are doing this in lots of different arteries. And what we don't have yet is a clear threshold cutoff value to optimally differentiate the fluid responders from the non-responders. So the bottom line here is not ready for prime time yet, but stay tuned because there's a number of people working on this and it may be ready sometime in the foreseeable future, and it's a lot easier to do than LVOT-VTI, and it's a true stroke volume surrogate, unlike IVC. All right, so the bottom line for ultrasound assessment of fluid responsiveness: IVC respiratory variation can be a good correlate in thoughtfully selected patients if you take into account their respiratory status and potential confounding comorbidities. LVOT-VTI is a true stroke volume surrogate with solid evidence behind it, but it can be very difficult to perform correctly. Arterial Doppler max velocity variation is fairly easy to do, may prove to be a reliable measure of fluid responsiveness once more research comes out, so stay tuned. All right, to review. If you're only going to remember 2 slides from this talk, this is your goal in fluid management, to hit this sweet spot. And these are the 3 ultrasound steps that you're going to do to try and figure that out. Here are all the additional references, and thanks for listening.